This is the intraoperative MRI workflow from my institution. The cadence of events differs based on which type of intraoperative MRI the institution has, but currently, this is for a fixed scanner mobile patient setup. It behooves the provider to remember that MRI safety is the foundation of this workflow and no steps should be skipped when double and triple checking safety protocols. This slide provides images for fixed versus mobile scanners. In the first image, 135-4, this is an example of a fixed scanner mobile patient. The patient is moved into the MRI room and the machine stays in place. In figure 135-5, this is an example of a fixed patient mobile scanner. The patient stays in place in the operating theater and the mobile scanner is moved into the operative theater. This means that the whole operative suite needs to be MRI compatible. Pre-patient MRI huddle is when the entire operative team meets prior to the patient being in the room. The surgeon gives an overview of the case, positioning concerns, and a rough estimate of timing for the intraoperative scan. This is the time that the team checks the equipment to make sure it is functioning properly, i.e., the transfer bed is in the correct position and releases easily for transfer to MRI table, the neuronavigation system is on and functional, etc. This step places everybody on the same page and is an attempt to keep things running smoothly. For example, a simple malalignment of the bed can have drastic consequences when transferring the patient that could prevent you from actually obtaining intraoperative images later on. Preoperative timeout with the patient in the room is another step that is extremely important to making the cadence of events run smoothly. This is the time to make sure that the neuromonitoring leads are counted and secured if utilizing. It is also a time to be certain there are no temperature probes on the Foley catheter, no metal in the large gauge IVs, etc. This is the last time the patient will be uncovered, so a thorough investigation should be undertaken to make sure there are no towel clips accidentally placed to hold the arms, or any other metal components such as scissors or a shaver are hidden within the bed sheets. The MR scanner circumference template check is also imperative, as any changes need to be made to positioning prior to registering the neuronavigation system. This begins the transition to MR scanner, and it relies heavily on a team approach. The surgeon secures the sterile operative field, and the scrub technologists count and recount the surgical instruments and equipment and maintain their sterile field, all while MR techs, anesthesiologists, and neuromonitoring staff are at the head, readying the patient for transfer to the scanner. Another timeout is performed, as well as a metal check to verify that the patient will be safe to transfer to the magnet. Once the transfer is completed, a discussion with the radiologist and their staff is important to determine if half contrast should be given in the event there is a high likelihood of repeat imaging after further resection. It is also invaluable to discuss the imaging results with your staff neuroradiologist, as there are subtle imaging differences when imaging through an operative cavity that is not remotely closed. These are photos of our setup. Multiple run-throughs are completed and only properly trained staff are scheduled to these cases, as the minutiae can easily be missed and shortcuts should not be taken. Several tips that we realized along the way include making certain your MRI-compatible head holder does not dip below the transfer table plane. You may have to use larger bolsters to elevate the patient, so this is not a problem during your positioning. Another such situation was securing the sterile field during intraoperative MRI. We placed Raytex sponges in the surgical cavity, irrigated it profusely, and then placed another sheet of Ioban over this. Next, we placed blue sterile towels over the newly placed Ioban, followed by a frame of tegaderms cut to size to secure the blue towels in place. Thereafter, another sheet of Ioban was placed on this entire field, with care being taken to make sure the Ioban laid within the tegaderm frame. This allowed for us to easily remove the blue sterile towels while maintaining the sterile field underneath. The tegaderms are less adherent than the Ioban, thus making for quite the seamless removal. These images are showing the transfer process of the patient from the operative table to the MRI table. One must be sure that the airway is secure and that there is an absence of lines and tubes interfering with transfer. The pre- and intraoperative MR images are shown on this slide. Again, it is important to discuss these images in real time with your neuroradiologist so together the images may be interpreted correctly.